Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Abdul Hadi Khan and my roll number is BP1650003. I'm a student of 4th Prof Morning and my group number is 12. The topic that I'll be presenting today is fluid and electrolyte balance, and I'll be focusing on potassium. Potassium is an important mineral and it plays an important role in maintaining the normal action potential and regulating normal heartbeat. The total amount of potassium that is being stored in the body is approximately 45 to 55 milliequivalent per kg, and it can vary with age, gender, and muscle mass. The plasma potassium concentration is actually maintained with a narrow range, that is 3.5 to 5.0 milliequivalent per liter, because if it slightly increases or decreases, it will give rise to conditions such as hypokalemia or hyperkalemia, which we'll be discussing in a bit. Now, potassium homeostasis is maintained by both renal and extrarenal processes. The renal process actually regulates the total body potassium by matching potassium excretion to dietary intake, whereas the extrarenal processes regulates the potassium distribution across cell membranes. Now, hypokalemia is a condition in which the plasma potassium levels are lower than 3.5 milliequivalent per liter. And the causes of hypokalemia includes diarrhea, vomiting. It can also be developed in renally compromised patients, and it can also be associated with intake of diuretics. Now, lower intake of potassium-rich diet may also contribute to hypokalemia, which is pretty unlikely because most of the food material that we take, they are rich in potassium. Excessive consumption or intake of alcohol can also be associated with hypokalemia, and diabetic ketoacidosis has also been associated with hypokalemia. The signs and symptoms are different. If the hypokalemia is temporary and for a short period of time, the person may not experience any of the signs and symptoms. But if the condition remains for a longer period of time, the patient or the person may suffer from weakness, fatigue, and muscle cramps or twitching. He may also experience constipation and abnormal heartbeat. Now, hyperkalemia is a condition in which the plasma potassium concentration is more than 5 milliequivalent per liter. And the causes of hyperkalemia includes the renal abnormality, if the person's renal function is not normal. It can also be associated with the intake of potassium-rich foods such as banana, spinach, etc. And Addison's disease can also be a reason of hypokalemia. And hormonal disorders, which includes the aldosterone. Some drugs such as the angiotensin converting enzyme inhibitors, ARBs, and beta blockers can also cause hyperkalemia. Now, signs and symptoms of hyperkalemia includes abdominal pain and diarrhea. It can also include chest pain, muscle weakness or numbness in limbs, nausea and vomiting. Now, a patient named JP, who is 60 years old, is suffering from malaise, generalized weakness, and nausea and vomiting for the past 3 days. Now, she has a history of hypertension for the past 20 years. And currently, she is taking hydrochlorothiazole 25 mg per day and nifedipine extended release 30 mg per day. Now, after checking her blood pressure was found to be 130 per 70 millimeter of mercury while sitting and 120 per 70 millimeter of mercury while standing. Her pulse rate was found to be 80 beats per minute while sitting and 95 beats per minute while standing. Her potassium level was found to be lower. This indicates the condition of hypokalemia. On checking her pH level, it was slightly on the alkaline side, which is 7.5 7.50. The normal range is 7.35 and 7.45. On doing the urine analysis, we found that the potassium level is higher in urine, which indicates towards the point that the patient is actually excreting excessive amount of potassium in urine. Now, upon assessment, some of the possible reasons were found to be the patient was actually suffering from nausea and vomiting for the past 3 days. So due to the decreased intake of the oral potassium-rich foods may have contributed to hypokalemia. Metabolic alkalosis, because her pH level is higher, may have been one of the causes of hypokalemia in JP's case, because increased pH level promotes uptake of potassium by cells. Now, the loss of gastric secretions due to vomiting may have contributed to hypokalemia, because the gastric secretions contain about 5 to 10 milliequivalent per liter potassium, which is very low compared to the intestinal secretions, which contain around 90 milliequivalent per liter potassium. So this particular reason will not contribute that much to hypokalemia. The next reason is pretty much important. The loss of hydrogen ions in gastric juice results in elevated plasma bicarbonate concentration. Now, the increased amount of bicarbonate ions as non-reabsorbable anions increases water delivery to the distal nephron and enhances sodium reabsorption and potassium secretions, resulting in hypokalemia. And since we have done the urine analysis and we found that the potassium level in urine is excessive, indicating towards the point that the final reason may contribute to the most loss of potassium from her body. The plan includes 40 milliequivalent per hour IV infusion in a non-glucose vehicle, because actually glucose induce insulin release, which can cause increased uptake of potassium by cells. She can be given up to 400 milliequivalent per hour per 24 hours. This is the maximum dose that she can be given. But there is a condition. These all things should be done in presence of the continuous ECG monitoring. Once her potassium levels are close to normal and she is able to take the oral medications, then she can be given potassium chloride 20 to 40 milliequivalent twice a day. Thank you.